Good morning or good afternoon or evening, wherever you may be. I'm Dr. Indoparandawa, the founder and CEO of the Food Allergy Institute. Welcome to our monthly webinar. We like to cover different topics across really the entire scope of what is allergy and allergic diseases. And today we're going to spend a little bit of time talking about the immune system, particularly towards food allergy, of course, and how it develops and how it helps really helps us understand how the immune system can lead to something like life-threatening food anaphylaxis. We'll go ahead and go through a number of different topics thereafter specific to the tolerance induction program, as obviously I know all of you are interested in that, and we'll be happy to speak towards those components. And then lastly, we'll end with a question and answer session open to any and all questions that you may have. So again, welcome. Appreciate you being here. Would, again, as always, like to advise if you can, turn your camera on. We're all here in the same community. That'd be great. So some of the topics we're going to discuss here specifically is at a high level, how the immune system is developed, specifically how it works. Why is it that this immune system is willing to act against itself, specific to food allergies? How the immune system changes over time. What happens in the early phase of life, we call these milestones, and then what happens obviously as you reach adulthood. And as we continue to accept older and older patients into our program, I think it's an important concept to discuss. Next, we'll talk about how the immune system, the development of the immune system actually impacts the concept of therapeutics. Like if you're actually to go for any form of food allergy treatment, how does the immune system development actually impact that choice? I'll go into some details specifically there. The tolerance induction program, obviously, this is a program that I've developed now for over 20 years, and we'll go into some of the high-level details of that. And then, of course, how TIP specifically retrains the immune system. That is what we do very, very well. We have patients in remission here now over the last 20 years. To take patients into a state of disease remission is very unique. That is something that we don't do very often in modern medicine. That requires an exact retraining of the immune system, and then we want to understand what that looks like long term. And then, of course, we'll go into general factors about treatment itself, and then, of course, our open Q&A. So let's go and kick it off. When we talk about the immune system itself, it's very interesting. I feel like it's an area of medicine that's often just not talked about very much. You all see your general doctors, you go get an annual checkup, and how often is your immune system even mentioned? The answer is generally not very much. One of the key components of the human immune system is that it has to function in a way that allows what's called homeostasis to occur. Homeostasis is just the true balance of how different organ systems should operate and come back to a point of propagating themselves. So essentially, we like to see human immune systems be in a good state of balance. In order to achieve that balance, the human immune system has to do the basics. It has to work well towards infections. So really one of the key components of the immune system is to recognize infections, infectious disease, and go ahead and try to clear those things out as quickly as possible. The other main component is to then educate the immune system to a point where if that allergen or if that infectious component, if it ever comes back again, there should be a key memory to that point. And the next time that interaction occurs, it will clear it even more efficiently. That's a really key component of how the immune system operates. But in the case of food allergy, it operates to the negative, where if the wrong interaction occurs with the immune system at a young age, it can result in the wrong memory being attained, so that on the next exposure to a food or the subsequent exposure to a food, it actually amplifies a response that does not result in homeostasis. So you never achieve that balance again. And over time, those reactions can get worse and worse. And for particular food allergens, that memory becomes very distinct and it becomes very firm, and it becomes very difficult to, quote, outgrow that allergy. And so that is the process of memory that, again, is very useful for certain aspects when you consider things like healing and repairing, particularly towards things like cancer or other types of oncologic diagnoses. It is a critical component of immunotherapy that is going to need that memory aspect to go attack certain cells. We also see the same approach in the immune system towards autoimmune disease. So really, the immune system is key, and it is key particular to the identification of very specific aspects of different invaders, different things that are getting in contact with our immune system, and how they actually respond to those things is key. What we've done here in this organization is take this concept of understanding how the human immune system interacts with the interface of different types of proteins, and we've applied that now towards food allergies. So we are able to study how the human immune system interacts with not just 9 main food allergens, but literally hundreds of different protein sequences that allow us to see how an individual's immune system looks essentially through a lens at all of these different food proteins. We've then built that through a lot of applied math into what is our tolerance induction program. The immune system is very different as you grow. There are certain milestones that are important to remember. Those are roughly around 6 months to 1 year of life, again around 4 to 5 years of age, and then again around 10 to 11 years of age. Those are very important milestones because the majority of the education of your immune system is occurring at the front end of your life, right? So think of it as going to university right away. You're learning all of these things in the first few years of life. And then as you get older, much of the changes that are occurring are towards this concept of memory and sustainability. These immune cells must continue that immune response for long periods of time, often a lifetime. And that's important for us to have the longevity and kind of the best health possible. So the human immune system, when you're very young, is extremely adaptive, meaning it can really see a lot more total number of allergens or a lot more total number of protein sequences, and it could try to adapt to them in short runs. So it does it for brief periods of time. Sometimes that's 3 months, sometimes that's up to a year. The initial response is quite robust. So you can take a young immune system and it could be trained a certain way, but the question is, will it maintain that level of training for a long period of time? And if you study this type of process across things like vaccines, or you study this kind of process across things like allergy shots, because that's something that's pretty common, it's out there. We have seen that when you do those types of therapies in very young children, if you don't have a real long-term sustainability plan, then they will actually lose that type of immune response over time. So best examples like allergy shots. If you start allergy shots in a young patient, say they're 5 to 10 years of age, they'll have a nice response initially, but there's a very good chance that they'll have to repeat allergy shots when they're 25 or 30 years old. So that training that occurred at a young age simply did not maintain itself for a long period of time. The adult immune system is a bit different. It does not have that same initial adaptation, but it has a much better long-term memory and long-term training response. So getting an adult immune system to achieve that effect and maintain it is something that's much more predictable. Up to a certain age, generally the 6th, 7th, and 8th decades of life, the immune system tends to become a bit less responsive, and it tends to not be able to go back to that memory and pull it forward to achieve certain immune effects. Nonetheless, we have all of this generally, I'd say, figured out as far as the tolerance induction program. We've had patients who start as young as 6 months of age. We have patients in the program who are in their up to age 30, and we are following those patients where now those same patients are in their 30s and 40s. So we have a lot of data across the entire spectrum of how this process operates. And the good news is essentially the immune system, once we identify all of the different allergens that are causing their allergic response, we can actually track that over time. And we do know how to sustain the response of remission. In fact, we're able to drive the sustained response of remission deeper and deeper over time in a whole wide variety of immune systems. We're talking about immune systems that have autoimmune disease, immune systems that have immune deficiency, immune systems that have other types of risk factors of familial disease. And I think having this type of large-scale data gives us a lot of confidence. And I believe that one reason we've been extremely successful is that we are only using native proteins, right? We're not using anything synthetic here. So we're using very specific, you can call it pharmaceutical grade amounts of biosimilar proteins, but we're not using anything synthetic. So the immune systems that we are tracking over time are adapting to these very native proteins that have been interacting with the human immune system for certainly the 100,000 years that humans have been around, and certainly to all of its predecessors. So that is the process that works well for us, and hopefully that's a good introduction to the concept of what the immune system should do. And the ultimate goal is to once again achieve homeostasis. How does the immune system develop, impact the concept of treatment? This is a very, very important question because uh, really the last 25 years has seen the first real attempts to take a disease like food anaphylaxis and try to do something with it, right? So you go back to the late 1990s, that's when the idea of OIT came around, where you just are using, small amounts of blind treatment. Essentially, you're just giving somebody small amounts of a diluted form of peanut or a diluted form of a certain allergen, and you're trying to induce the immune system into a state of desensitization. So you're trying to desensitize the immune system. The problem with desensitization is that when you try to desensitize an immune system, it is a short-lived effect. So it generally only lasts 24 to 96 hours. And then if you were to stop that actual treatment, that type of desensitization, there's a rebound effect where the reactions that can occur there are quite robust, and the reactions do come back. That type of short-lived response of desensitization is something that can occur in children a lot more or a lot faster than adults. And in fact, if you look at all the trials and tribulations in the last 20 years, OIT has not been successful in the adult population. And it's because of that adult immune system does not really like that hard push at the beginning. It needs a much more exact and strategic approach to actually identify what that adult immune system is reactive towards, and then it has to build the right type of memory moving forward. So OIT as a whole, I think, again, this brute force approach of just trying to push these allergens through an immune system, while it has had some degree of success, has certainly struggled to become widely scaled up because of because of this approach, and because of the ability of the immune system not to utilize this desensitization method long term, or let's call it successfully. The other option is a drug like Xolair, which was FDA approved last year. And again, Xolair is a medication that's used to not treat food allergies. Let's be very clear about that. It's not treating it. It's essentially giving the food allergy a cushion. It's basically an antibody that is absorbing a certain number of the allergic proteins that float around the blood, and reduces the risk of a reaction, but it does not eliminate it by far. The interesting thing about Xolair is that it's been around for 20 to 25 years. It's been used largely in adults, only more recently taken all the way down to age 2. And certainly it does have a beneficial effect as far as providing a cushion, but it did not do so in a predictable manner. So you cannot say for every patient that on Xolair you're going to have protection of, let's call it, one peanut, or protection of one, fourth of a teaspoon of cooked egg, or something of that nature. And in fact, some proteins like cashews and pistachios, it did not offer any level of protection. And that's a concern. And the question should be why? And the answer goes back to the immune system. The immune system of every individual is uniquely different. Depending on their stage of development and what type of memory they have, the human immune system can far outproduce the effect of what Xolair can do. And so that becomes a question, because you think staying on these injectables multiple times a month for many, many years, if it's not really coordinated or dialed in properly to that immune system, there can be a time when that immune system cannot overcome the effect there of something like Xolair. I'll leave it there with those two particular forms of treatment as it is. Again, as far as TIP is concerned, we'll go into more details about that, but the tolerance induction program is a highly strategic form of immunotherapy. It utilizes biosimilar proteins. It uses hundreds of trillions of data points across 20,000 plus patients who have been in our system over these years. And it allows an exact approach that is patient specific. It utilizes non-synthetic proteins, and it utilizes an approach that actually convinces an immune system to reach a state of deep remission. So it's a very different model, and it adapts to every immune system, no matter where they are in immune system development, at a very high rate of success. Our ultimate goal here at the Food Allergy Institute and with TIP is very simple. It's called remission. We're not looking for anything else. We want any patient who has any form of food anaphylaxis to be able to come in here and leave the program never having to deal with food anaphylaxis again. Full stop. That's what we do, and we've done for 20 years. That type of goal, I would argue, in any disease, is something that you don't hear people say. People don't go to their general doctors and hear a doctor say, we're treating you for, heart disease. And our goal is to make sure you never have any sort of cardiac events or sort of cardiac risk factors. We have the ability to make these statements because we are doing this across large scale data under extreme regulation and with long-term outcomes that have been proven now for the last 2 decades. We are also able to do this successfully because of this data-driven model uses a high level of accuracy through our machine learning and AI systems that we've built here in-house. And of course, we've published and peer-reviewed this across now many, many times over. This form of highly advanced care is excellent because not only does it allow for an exact precision to the approach of care, but it allows us to really have a lot of levers to utilize, even if you're in that very small percentage of patients who happens to have any sort of concerns during the program. The levers that can be used are many. So we can take patients who are having even a little bit of a problem or a significant problem, and we can adjust their case based on data, and we can get them moving forward back to the same goal, the goal being remission. Remission for us is very simple. We want patients to consume all of their allergens as if they were non-allergic people. So if they were anaphylactic to dairy, they should consume dairy like a non-allergic person. That means they're drinking glasses of milk, they're eating ice cream, cheese, and so forth. If they're allergic to peanuts, they're consuming peanut butter, peanuts themselves, any peanut product without restriction. If they're allergic to seeds, they can consume any seed product. They can eat hummus with lots of tahini sauce if they're allergic to sesame, and so on and so forth. That is something, again, that no one else is trying to target because they're not necessarily trying to target the concept of remission. Our definition of remission also means that at the end of the program, the majority of the food proteins that you have to utilize for that entire process are consumed on a weekly or biweekly basis, or even less than that. It allows an individual to have the right amount of sustained responsiveness is the term we actually like to use. Or we actually like to make sure the immune system is not going to ever trigger back into a state of allergenicity, as long as you're maintaining the right treatment path based on the actual case that is provided you by our machine learning and AI systems. We treat patients who have multiple allergies. In fact, that's the majority of our patients. Somewhere around 2/3 of our patients come in with at least 4 or more primary anaphylactic proteins. We are treating all of them simultaneously. While we are treating, I'd say the majority of our patients are high risk and have often tried other treatment programs, and now they're coming to us. We certainly get the what I call bread and butter cases too. So patients who have 1 or 2 allergens, they haven't been treated by anyone else. We take the whole gamut. It's not a concern. We also treat patients who have any significant pre-existing conditions. If you look at any other treatment options out there, often there are significant restrictions. So if you have persistent asthma, they don't allow you to do treatment. If you have severe eczema, you're not allowed to do treatment. If you have any autoimmune disease, you're not allowed to do treatment. Here, because we are very confident in our approach and we have multi-level of specialists available to support the care of our patients, we take patients, all comers. We've had patients come in with organ transplants. We've had patients come in with all types of autoimmune conditions as well. So it's something that we've gained a lot of experience with, and all of those patients have achieved the same endpoint goal of remission, which is really wonderful. So how do we ultimately achieve what's called sustained unresponsiveness? Essentially, the idea that you can consume something that was so allergenic that it could trigger a life-threatening reaction. How do we go from that to a point where you can actually consume the food protein openly without restriction? Well, it's essentially going back to how the immune system can be modified. What does it take to make that happen? And years ago, as a transplant immunologist, as someone who studied this incredibly complex approach of saying, how do we take an organ and give it to somebody and successfully get that recipient's immune system to accept that organ long term? I used a lot of the same approach in understanding how an immune system would adapt to a specific protein like peanut or dairy or walnut or any primary allergen. And in doing so, we had to identify all of the epitopes and protein sequences, all of these very key components that make up food, and determine what is it that the immune system needs to see in order to adapt and to accept that protein once again into homeostasis once again into a position of tolerance and ultimately remission. That required, first and foremost, the ability to diagnose. So we had to really change the way diagnostics work. So for 20 plus years, we have been on the forefront of developing the newest diagnostic testing available. In fact, many of those things are now commercially available, but within our system alone, we're able to run the highest level of diagnostics with the highest level of accuracy. This includes blood-based testing, skin-based testing, patch-based testing, and more. So we take 400 plus analytes per patient. That is fed into our machine learning and AI systems, and that ultimately gives you a snapshot, an ability to understand what your child is anaphylactic to, and more importantly, what they're not anaphylactic to. That is key. And then we utilize biosimilar proteins to actually cross-match the immune system of an individual to ultimately accept proteins in their primary allergen. We will produce those key proteins in-house in our own manufacturing facility that's highly regulated in these gummies that you see here. And that really, really tight control of cross-matched biosimilarity over time allows somebody who's anaphylactic to peanuts to ultimately consume 60 or 75 peanuts, depending on their weight at the end of the program, without a symptom, and ultimately allows them to consume the food without any sort of restriction long-term. That allows patients to achieve what we call food freedom and the ability to live their life without restriction, and for parents not to have to worry. And this entire process is the tolerance induction program. It is how we retrain these immune systems, not only for short, episodes, but really for an entire lifetime. To some of our patients and some of our process, I think when I talk about this program and see how much it's grown, it's important to understand that, if you haven't been here and you don't know much about our organization, that this is not another doctor's office. This is a large organization. We have hundreds of employees. We have 125,000 square feet of space, multiple locations, and we take this very seriously. This is all we do. We take patients with food anaphylaxis and we put them into remission every single day. We're reaching about 2 patients hitting remission every single day on average right now. And again, it's tremendous work. It is by all means a major commitment. It is something that I think every parent here who's on the call understands what it means to be committed as a parent. I have 3 kids myself. It's something that you have to essentially ask yourself, are you satisfied with the possibility of a future where your child grows up into a young adult and still has to suffer on a regular basis with the life-threatening nature of food allergies? Or do you want to have the opportunity to put in the commitment, do the work for a period of time, a couple of years, with a lot of support? I mean, we give our patients a tremendous amount of support, and ultimately they get to a point where they don't have to live this life anymore, and they can consume and eat as a non-allergic person. All the stress and strain that comes with it is in the past. And, still the greatest thing that I love seeing on a regular basis is our patients who are out 2, 3, 4, 5 years or 10 years. I get messages from them on a regular basis, and the word is life-changing. That is the word that's used most often. And when it is life-changing, it means that everything is different. And this is a long-term benefit. And the victory lap that parents take from there is really just phenomenal. So it's a process that is certainly well worth considering. Are there any long-term effects to the immune system after a child reaches remission? The hard answer there is no. Again, we are using non-synthetic proteins. These are native, natural proteins found in plants and in animal proteins. We're using them dialed in. We are changing them when appropriate, only based on denaturation. Otherwise, they are literally the same native proteins that humans have been around for a very long time. We have not seen patients develop any sort of, additional problems or additional comorbidities. Keep in mind, these patients are coming in with other allergic comorbidities. So they do have other medical problems like asthma, like eczema, and so forth. And I'd say the great thing about this program, because we are studying everything that interacts around the world of allergy and immunology, is that they will enter the program often with eczema, asthma. Some of them have different types of gut diseases like EOE and things. And by the time they're done with the program, not only can they eat whatever they want, whenever they want, without restriction, Their asthma is often under excellent control or in remission. Their skin is much, much better or in remission, and their EOE is much, much better or in remission. And I think that is what is really quite incredible when you start to understand the layers of the immune system and approaching the treatment process accordingly. And I'd say the first year of remission is the critical year. Once you hit remission, you're going from a time frame where it's a very tightly controlled program for a couple of years to now you're in the remission phase, where now the immune system has or must develop a time component to what that looks like. For example, previous to remission, a lot of the dose protocols that are done here in the program are daily or weekly. Now you're in remission and pretty much everything is weekly, biweekly, or even less frequent than that. So now the immune system has to manage 7 or 14 or 21 or 30 days and figure out how it adapts. Again, the vast majority of patients do extremely well in the first year of remission, but we have roughly about 1 in 100 patients who will have some symptoms. Nothing severe. Those patients are put right back on track because we have the data and we have the full system, 24/7 command control, escalation systems, all run digitally. So no matter where you live, we are managing, monitoring, keeping it under control. By year 2 and 3 of remission, the incidence of reports are essentially zero. And past 3 years of remission, unless somebody is really, really negligent and stops eating everything, we essentially don't see any symptoms of any kind. So again, remission for us is the goal for every single patient. We have the protocols, the data science, everything's in place to make sure that long-term, as your child goes from being a 5-6-year-old all the way to being a young adult and beyond, that we have a lifetime form of support here for these patients. Again, something you just don't see in modern healthcare. Healthcare in the United States and really globally is separated. Everything is broken up. It's not a uniform form of care for your entire life. That's something that we strongly believe in. We will do everything possible to support our patients, not only through the initial phase, but well into remission. And, patients who are out 5 or 10 years in remission, sometimes we have a heck of a time getting them to come back, I'll tell you that. But, we still do everything we can to make sure that happens as well. But it's really, again, it's a game winner when it comes to leading a lifetime without having to deal with food allergies. As far as when's the best time to treat, I'd say the primary factor you have to consider is your level of commitment. It's really that simple. If you are committed to reaching remission, reaching food freedom, then the time to start is now. If you believe that, you have more questions, we're here to answer those questions. If you believe that, the time commitment may be too much, then again, that's something that I think families have to go back to and say, all right, well, when is the right time? When is the right time to actually, make this happen? Based historically, our patients find that, when your kids are younger, sometimes it's easier to do this because you have a little bit more time, a little bit more flexibility. But I'll tell you that every patient who's finished this program, let's say they're in their 20s, the number one comment that I hear is, I wish we did this sooner. I wish we did this earlier, because it makes a big difference. Think about lifetime. Think about the time and years of life that you have available to yourself or your child. The more years you can give them living without food allergies, I believe is the best way to go. And that's really the way to look at things. The other thing you want to consider is, will your child consume food proteins, right? So, food is food. And certainly, in this program, it is a commitment. You are eating a certain amount of food over time. When the patients are done, they have literally consumed kilograms. I'm talking large kilogram amounts of various kinds of nuts and dairy and eggs and things of that nature. So while it's not an overwhelming amount of food, it is certainly food protein. So somebody who's an extremely picky eater, that's something to consider getting some support. Again, we're here to help. We can certainly give you some guidance on how to manage, that the concept of a picky eater. But what we've also found is that many times kids with food allergies are picky because they have components of fear and they also have components of taste, where they are just very restricted on that approach. Once you get into the tolerance reduction program and they can actually consume food safely, especially in the early phase of the program, the previous picky eater becomes often a very good eater. And so that's something else to, consider and look at. I probably just want to say one last thing, which is, you also have to look at the key milestones of life, especially in childhood, and how that affects your decision making towards starting a program like TIP. Going from preschool to kindergarten, a lot of the control you can have at the preschool level is kind of gone in kindergarten. You have to hand off to the kindergarten school, hope that the teachers are serious, that they're going to take good care of your kids. There's a lot of good kindergartens out there, but sometimes things are out of their hands. And some child will bring something into school that, by accident has an allergen, and reactions do occur, right? So that's a key milestone where if you could be in this program before kindergarten, hey, that makes that kindergarten elementary school process much, much easier. By the time your kids are in middle school, you're looking at a whole different type of behavior, a whole different type of, kind of mental mindset, and a whole level of awareness to what they are dealing with in food allergies. I have middle schoolers at home myself. I see that development, very, very keenly. And it's tough, right? Because now for the first time, they're asking you, why do I live with these things? Why do I have this condition? And why am I treated differently because of it? That makes it difficult. Then you move on to high school, and high school is very busy. Everyone knows that. So sports, academics, social life, et cetera. And now food allergy kind of moves to the back of your mind. So you don't want to think about it as much. And that's when, again, accidents can happen and mistakes occur. That's really life limiting. And that during that very critical time of high school, it's one thing that would it not be nice to not have to deal with that. Then you move on to college. College is certainly, a tough time. A lot of independence, being on your own. The food at college campuses can be, brought into question from a food allergy standpoint. Same sort of questions are brought up there. And, again, would it have not been nice to not have to deal with that during college? And then lastly, young adulthood, going into your first job when everything is about food, everything is about, finishing an internship and spending the, happy hour or whatnot in certain restaurants. It's very restrictive when you have to announce and limit yourself. And, that has real implications in early career development. And I mention all these things as someone who's seen it firsthand for 20 years. And hearing all of the patients who finished the program during these milestones and after these milestones say what a difference, the tolerance reduction program has made. So I'd say, again, the word I used was commitment. It is commitment, and it's commitment to do anything. It's commitment to put your child through school and get them educated. It's commitment to put your child into sports and make sure they perform well. It's commitment to really anything in life requires time and real assessment to what you're willing to do. I wish I could tell you that there was just a little pill that you take and it's all gone, but I will tell you that most of modern medicine does not offer such a thing for any disease. Medicine is now in a position where it's getting better and more advanced, but ultimately we want to keep the native immune system or the native organ system as stable as possible for a lifetime. That's what we're looking for. So the initial commitment of this program is a few years. Again, if you have 9 top allergens, it's going to be a longer course of treatment. It could go up to 5 years of time. But if you have only a few allergens, it could be as short as a year, right? So it depends on what the actual case is. And that's why you have to come in and get your actual testing done. Once you start the program, the commitment is a run. It's, anywhere between 6, 8, 10, 12 weeks, depending on where you're flying from. And which allergen cycles you're dealing with. We're going to do the very best we can to shrink those cycles down. We'll try and keep it as efficient as possible. There's work to be done in the morning, work to be done in the evening, but there does come a rhythm to the process. And as you get through that rhythm, as you build up your community, as you work hard towards towards the process, you will reach the ultimate goals. And those goals don't happen at the end of the program. You don't wait 2 years to see the wins of this program. Most people are only waiting a few months. For the first time, you're able to consume foods that you've never eaten. For the first time, you're able to clear cross-contamination, where you can go to restaurants and bakeries and not have to worry about anything. And within a year, you're often eating an anaphylactic allergen completely that you previously could not eat. And that builds a huge amount of confidence in the patient. It builds a huge amount of confidence in the families and parents as well. And so ultimately, like I said, we look for a level of commitment because we're putting a lot of energy and effort into this, and you're putting a lot of energy and effort into this. And commitment on both sides gives us the success we're looking for. And that's in the end what we call compliance. Most of the dosing of this program and most of the treatment of this program is done at home. 99% of the program is done at home. That's also unique in the food allergy space. Nobody else does that. Now, we're able to do that successfully because of data science, because of the ability to produce proteins and package them, label them, and give them to you accurately. And with new developments like our patient app, this whole dosing process does become much, much easier. At home, we do have 3 forms of foods that are part of the tolerance induction program. One of them are called recommended foods. These are non-allergic foods that you're likely currently eating. We try to increase those frequency. We try to get a certain amount of those foods because they, again, have biosimilar proteins to your child's specific case that can help retrain that immune system. These are relatively straightforward and easy to use. They can be added to any breakfast or lunch in a relatively easy way. Then you have treatment foods. Treatment foods are the food proteins that we produce for you. These are often given to you in these nice gummies and tarts and other products that we've developed, again, under extreme regulation. And what this allows you to do is to take the safety in the process, and this is typically done in the evenings or late afternoons. We do ask for a rest period around this time just to make sure the immune system is able to adapt to this protein and not get pushed too much. But a 60-minute rest period is not a period where you're sitting still. This is not a period where you have to do nothing. You can certainly, walk around, go do some errands, you can play music, things of that nature. But, by all means, do not just sit there and not move for, 60 minutes. That is not the goal. And of course, at the end of our program, this rest period also goes away, which is another unique component of our approach in our organization. Once your treatment foods are actually challenged, so you're doing all of your treatment dosing at home for 6, 8, 10 weeks, and then you're going to come in and we're going to do this very large challenge to clear these food proteins. So let's say you were building up walnut, on these gummies, and it converts into whole protein. By the time you come back here, you're challenging 14, 16, 20 grams of walnuts, which is roughly half a cup of walnuts in one sitting. We'll make sure that you pass that challenge successfully. We do a lot of immune system stress testing in our clinical centers here. That allows for safety and effectiveness to occur. Then that food protein that was previously a treatment protein now becomes a maintenance food, which means you eat it in the morning or lunch, and you eat it pretty much in an unrestricted fashion like a non-allergic person. And so this maintenance approach is excellent because it continues to support those biosimilar proteins throughout the process until you reach what's called remission. So these are the 3 aspects of the tolerance induction program that allow food proteins to be delivered, run on a daily basis until you hit remission. Once you actually hit remission, again, all of the requirements of those food proteins move to weekly, biweekly, or lower frequency. And that just makes the whole process much easier. The commitment is there, again, for the initial phase of a few years, and then it becomes a markedly easier life thereafter. So just a couple last points here on things to consider. Children, who are young, and again, I say this as somebody who's, treated now well over 20,000 patients with food anaphylaxis. It is something that I did not understand when I first got into this space. I did not understand the psychological and developmental impact of food allergies. In fact, I think to this day, there's not nearly enough research done on this space. But, these kids, as they are younger and, again, start to hit that middle school timeframe, the impact on their mental health is absolutely significant. 1 out of 3 children with food allergies have been surveyed, and they experience direct bullying. They often will not tell their parents about what's going on. The impact on that is absolutely tremendous, especially in this day and age, social media. It all becomes additive. So, these are things that you want to think about. And imagine, once you're done with this program, that, all of those issues go away. Having sleepovers, birthday parties, play dates are dramatically different when you don't have to have this entire conversation about food allergies. And all of you know very well that that is not an easy conversation to have. And the response from non-allergic families is often something, something to be considered. It's not something that they often have a lot of empathy towards. When you look at, again, other treatment considerations, young immune systems, by all means, are very adaptable. Again, the question is, can they maintain the changes? We have the ability to forecast that effectively through our data science. We also know that as you deal with younger kids, you will have the ability to make sure that they, consume proteins on time, that they're tracked, I'd say through the program a little bit more accurately. That can be difficult as kids get older, but at the same time, again, it's all about level of commitment. We have plenty of patients in our program who are in high school and plenty who are in college, so it can be done. But often having that control, certainly that factor does show up more in the younger age group. And of course, the concept of picky eaters, as I mentioned, we're here to support that, but it's something to consider as you're considering this program. There are plenty of ways to creatively get kids to eat things. We have a large volunteer program. We have a lot of social media presence and a lot of real solutions that can make this whole process a whole lot easier. As far as older kids, again, we know that the challenges to them are right up front. They're certainly right in your face. Kids, as soon as they hit late middle school and high school, no longer want to deal with this additional label. It is a lifetime label unless we do something about it. That label often makes them encourages them to make sometimes not the best decisions. And so often it leads to high-risk behavior. That high-risk behavior can result in really serious negative events. And again, I've seen this so many times. It's what drove me to do this work. The truth is, you would think like not carrying your EpiPen is not a big deal, but not carrying your EpiPen is a high-risk behavior. If you have food allergies and you're not carrying your EpiPen and you're in the wrong place at the wrong time, we all know very well that that can result in something absolutely horrible. So, it's so sad and unfortunate that, young people have to go through this. But the truth is, food surrounds us everywhere. Food is a critical part of social existence. And, this is the reality of where we are. And as I built this program, I wanted to make sure that the end result of this program meant that no child or young adult who finishes the program should ever have to feel those challenges again, because ultimately it's something that would be behind them. And from an immune system standpoint, that would guarantee them long-term effectiveness as far as lifetime remission is concerned. And lastly, for young adults, again, we've treated patients of all age groups. And, as you get older and you live with food allergies, and 2/3 of patients with food anaphylaxis do develop food allergies after the age of 18. So many of them have known what it meant to live without food allergies, and developing it later can be absolutely detrimental. That creates a lot of social isolation. They often will not have the same type of social perspectives as others who don't have food allergies. Their rates of mental health disorders are much, much higher. And, again, it becomes very difficult when you are now on your own without the help of family. It does limit certain opportunities. We've had many, many patients who have come to us with the goal of entering and enlisting in the military, all branches of the military. And maybe you all don't know, but if you have a diagnosis of food allergies, you are not allowed to join the U.S. Armed Forces. And we have helped many, many patients, overcome that, which I think has been a great opportunity. So again, my opinion as the founder of this organization is if you look at life simply in terms of time, you want to give your child or yourself the maximum amount of time without living with food anaphylaxis. That's my conclusion and my approach. Hence, treatment, the best time to start treatment is now. A lot of things to consider in that process, but it's something that I firmly believe in. I have dedicated my life to this work. I have put in so much of my own funding into building this organization and this system. It has not been easy. This type of work is absolutely cutting edge. We've been recognized for that time and time again. I think our current healthcare system and current research model that we have has been woefully slow to answer questions for difficult diseases like food anaphylaxis. We've done it. The opportunity is now yours to, bring you or your child into our organization. So with that said, we're going to take some questions here. In the past, what we like to do is ask you to raise your hand. Second here. Yeah, 1 second. I will ask you to unmute, and then you can go ahead and maybe tell us where you're from, how you heard about the program, and go ahead and move forward with your question. We'll start off here with Tia. Hi, Tia. Good morning.
Hi, doctor. How are you? I have reviewed a lot of information on your website. I want to thank you for putting everything so straightforward on the website. I listened to as many workshops as I could before this QA session. So I'm from Maryland. I'm actually very similar to Heather's case from last QA. And my little one is 3. He has 11 food allergies. With environmental allergens as well. So before we have been working with Hopkins, University of Maryland, but the plan has been just monitoring it. There is no actions taken, so we feel so hopeful to see your program. So I have 3 quick questions. So the first one is, with recent advances in AI such as AlphaFold, what new applications do you see for this technology with regards to tip, or if this could change the whole field to treat food allergies?
Yeah, great question. That's a very complicated question, but I'll certainly answer it. For those of you who don't know, AlphaFold is a highly advanced protein sequence forecasting AI model that has replicated, or I should say, has at least been able to match the highest level of protein folding accuracy in history. Fun fact on that, it was actually developed by video gamers, or we call them gamers. The fact that gamers used applied math to predict what proteins look like in 4 dimensions tells you that applied math has a major role in science. Now, the way AlphaFold works and what it focuses on is largely currently based on prior historical categorization. So what that means is the majority of proteins that have been sequenced, in human history so far have been animal proteins that are generally disease or organ specific. So you're looking at like muscle proteins and cardiac proteins and blood proteins. They have not spent a lot of time on plant proteins, unfortunately. Now, that would be nice, but that's something we're working on. And we have our AI systems they're not as pretty as AlphaFold in that sense, but we also have various transformers, and we use a lot of evolutionary protein data, and we are, building up that type of modeling as well. But absolutely, I would love to see AlphaFold to, spend some time in the plant protein world, because it would probably make a difference in what we do and how we approach things. The flip of that is we are also trying to make sure that as we build our discovery models out, as they are applied to tip, we want to shrink the total amount of time that patients are in tip. That is something that has been happening for years. Tip has actually been getting shorter, but we believe that there's definitely room to make it even more efficient.
Got it. Thank you so much. Another quick question is that I think for parents who are very serious about food allergies or treatment for food allergy, I think your program is probably going to become popular in the near future. I wonder, what is your role in the treatment plan? Do you still personally oversees patients' treatment plans? And if your organization grows rapidly, have you put in place strategies to ensure the patient safety as well as the program's effectiveness?
Yeah, it's an excellent question. So, yeah, obviously we have scaled tremendously. I mean, again, we're not a doctor's office, right? We're a large organization. We have dozens and dozens of providers and physicians and multiple specialists, allied, health professionals as well, nurses and so forth. So we have over 100 employees just in that space, and that's for the on-site activities. And you can imagine there's additional hundreds plus employees who are handling all the digital activity, because we're monitoring patients from a distance, right? We've accomplished something very unique here in that we can diagnose food anaphylaxis, treat food anaphylaxis, and induce remission for food anaphylaxis, and largely do it digitally. That doesn't happen for any other disease. My role has absolutely changed. I mean, look, I started this program. I used to see every single patient. I would build every model. I would code everything. It was that level of seriousness, but there comes a limit to what one person can do. And so 15, 16 years ago, when we built our first machine learning models to trial level, it had to happen, and I was always wondering when it would get better than me. But it's been better than me for probably about 6 to 7 years. And so the reality is that, I built a system that outperforms the expert, and that's a good thing. What does our system do so well? Our system takes the human operator, the physician, the practitioner, and it makes them extremely good at what they do, right? So it's no different than kind of what robotics has done to surgery. Robotics has made surgery far more safe and effective at a cost, unfortunately, but it does really work much better. So yeah, my role is not in that position anymore. I'm not overseeing any all cases, and that has been my goal, because ultimately, if this program was dependent on me, it would never scale, right? So we want a system that operates. And the last point is that our safety profile has improved per capita, per case. If you compare us now to last year or previous years, every year we're getting better. So it's certainly not dependent on my presence to have this thing continue to improve. It will only get better with time.
Got it. Thank you. Last question is that if we do choose to work with you and have you guys treat my son, will you replace the role of allergist? Do we still need to have an allergist locally, or working with you alone should be sufficient?
Yeah, generally when you come here, we're one-stop shop. We kind of handle everything. We have all specialists, we have all teams ready. By no means are we trying to isolate allergists, though. I mean, we were just at the largest allergy conference here a month and a half ago. We had well over 1,000 allergists engaged with us. They recognize us now as a very serious treatment option, and they want to know more and want to work with us. So we like to have everybody engaged, but the truth is, look, this is very serious work. It's high risk, high reward. We would like to be the decision makers. We are the quarterback. We want to own the case. And
Yes.
so in that sense, we're happy to take that.
Yeah, so it's okay if we stop seeing allergists locally, because we really haven't been receiving much support except getting a blood order. So you would say
Yeah.
it's okay to stop seeing and then just continue to work with you.
Yeah,
Okay.
look, it's your story. I mean, it's your decision to make that, but your story is similar to, I'd say, most other people who come here. So,
Yeah.
but,
Thank you so much for your
all
time.
right. Great questions. Thank you. Next up is Summer. Hello, Summer.
Hi, Dr. Rondala. Question. Well, first of all, I'm Summer Boudreau. I have a 10-year-old daughter with allergies. I've tuned into a couple of these, asked a couple questions. I found you through Graham's mom, Sarah, her online presence, while doing research. And the closer we get to committing to the program, I was thinking of travel and such. I have a lot of fear associated with this. So do most of the reactions happen during that updosing appointment? And whenever you are doing these challenges with multiple food proteins, how do you know which one is actually causing a reaction if they don't pass the challenges?
Yeah, great question. So we're doing about 3,000 food challenges a month in our system, right? So again, that's a huge number. Major universities are often doing 5 a month, right? Just to give you an idea of what we do versus others. Out of 3,000 food challenges, our rate of reaction, so this means that any symptoms on a reaction, is right now 1 in 900. So you have a 1 in 900 chance of having a symptom. Most often that's hives or a stomach ache, and that's usually after we put them through our immune system challenge. So remember, we're exercising, we're doing all this stress testing. For the 1 in 900, that reaction is happening on site. So we will resolve it on site. We'll make sure it's gone, and you'll be, on your way. You're good. How often do we have an EpiPen deployed in our centers? I believe in 2025, we had a total of 3 across all challenges. Now, I won't go into all the details of that. Again, one of them was a very, very complicated case that, let's just say, a highly, highly complex case, and such was that. 2 of them were non-compliant, and they didn't tell us they weren't eating things, and that's life. But did fine, no problems. They're back on track. We keep moving. So the incidence of reactions on site here are get very low, but they do happen, and we do have a system to make sure that it's controlled and we get patients moving right in the right direction. As far as their the risk of reaction, like, so you get back on a plane and it's going to happen on a plane. That has not happened historically. I'd say maybe 15 years ago, we had a case, and I still think the child probably ate something before they got on the plane that seemed to have triggered it, but it does not happen. Why does it not happen? Because the system's built to kind of capture these things, right? So we're going to do the challenges on site. We're going to do the immune challenges. Have we had reactions occur when patient leaves the clinic? Rare. I mean, I'd probably say maybe once a year, but it's usually within an hour and a half, 2 hours. We bring them back, we resolve it, and we're done. But ultimately, we need to capture them before you get on a plane. I'd say most of our families, they end up doing afternoon challenges. They hang out for the night and they leave the next day. That's kind of what most parents do. It seems like what they're most comfortable with. And that's totally fine. But we have also many parents who fly in the night before, do the challenge in the morning, fly out in the afternoon, right? So that's the general rule. Definitely seems to work well. And we've not had any major concerns. Thank you very much. And next is Rocio. You can go to unmute and ask your question, please.
Thank you so much. Let me turn on my camera as well. Thank you for this conversation. My daughter, she has a lot of issues, and she had anaphylaxis at 10 months old, and we took her to the program when she was 2. There's a long wait list. There's like these fees coming in. She had an assessment, and she was told that she potentially had EOE and that she was not a candidate. So we went to GI, and what GI explained to us is like, look, this kid is gaining weight. She's developing healthy. We can't, like, if we start doing EOE monitoring and scoping her, it could be much more impact. Well, she's still growing, but it's super challenging with the food allergies. And with GI, we agree all we do is avoidance of allergens, and that's how we manage a potential EOE because she's never gotten the diagnosis. I really want the help. I know the psychological impact has been tremendous. Like, she's been on therapy since she was 2. But how can I tell, 2 questions here. How can I tell that she would be a candidate without having to go through the whole, ordeal in the beginning? And 2, is there a role for personalized medicine here? Because her system seems very different. Like, she's diagnosed with mast cell activation syndrome. She has hyperflexibility, hyper IgE. Like, it's a very complex case that we really rarely get much help with conventional medicine. In interventions, we've done a lot of functional medicine, which helped her broke her eczema. But I'm concerned to be, like in a belt of treatment where I know she can have certain predispositions. So yeah. Thank you. Those 2 questions.
Yeah, great question. Sorry to hear that. I mean, again, the majority of our patients are very complicated. So everything you just described is not unfamiliar to us. We've seen it, managed it. Is it hard? Absolutely, it's hard, right? I mean, when you're dealing with complex cases, you need to spend the time to stabilize and make the right diagnoses before you move forward. As I always tell our teams here, TIP works well when you have a normal immune system and normal anatomy. Normal immune system, normal anatomy. So that means if you have an immune process going on, we need to understand it and make that immune system normal. And if there's an anatomical issue like EOE, we need to understand it and make it normal. And then we can proceed with treatment. I think every one of our cases is highly personalized. If you look at how the data is gathered, how the data is utilized, every single patient has a unique treatment protocol that is for them. For your daughter's case, to answer your question in short, it's ideal to at least do the intake, and kind of gather all the data, meet with our medical group and say, okay, how complex is this? What does the path forward look like? I think that's often a worthwhile endeavor because we're not going to send you down a rabbit hole. We're not going to, I mean, you've been down that rabbit hole, I can tell. Mm-hmm. So it's not something that we do. We are here to help and be, earnest and transparent about how we operate and what we do. But I mean, everything you mentioned so far is not a major concern. I have a example. I have a young boy who's been in our program for a couple of years now. His father is the head of surgery at one of the major hospitals here in California. And he would not gain weight. He had all kinds of issues, et cetera. And, again, it takes some time to identify what roles or what kind of factors and roles are occurring in the immune system, in the GI tract. Ultimately, we found a pathway forward for him. He's now gaining lots of weight. He's overcoming all his anaphylactic allergens, and he has a clear path to the finish line. So, again, often is the case. It just takes a true comprehensive approach to really understand what's going on in your daughter's case. And then the deployment of treatment has to match that comprehensive approach. And you should not lose that comprehensive approach over time. That needs to be consistent.
Okay, so if I understood you correctly, like if I present again to the program, it's less likely that they're just going to send me, no, she's not a candidate, come back in a few years, but they're going to engage with me in the process and following up with other doctors and things like
That's
that.
correct. I would only advise that, we do only treat anaphylaxis, right? So we should know that there's an anaphylactic aspect to things. We've had some patients come in who do have no actual food allergies, and in that sense, our system is not able to manage those cases.
Okay. Yep. Thank you.
You're welcome. Next up is Paulina. Hello.
Hello. So just two questions. Is it possible for once a patient is in remission for the immune system just like randomly start reacting even though they're doing their maintenance? Is that like a thing, or it's just like not possible that could happen?
Yeah. So the question was, is it possible for someone who's reached remission to essentially lose all that they've gained and go revert back to anaphylaxis? Again, the short answer is it should not happen, right? It's exceedingly uncommon. I would say that the only time I can think of a case or two is right within the first week of remission. I know it sounds strange, but like they somehow just passed the remission visit and something in their immune system is not quite balanced, and then they kind of revert back. They don't revert back all the way to being anaphylactic, but they do revert back. That's really, really uncommon. Do we have patients who reach remission and have some symptoms? As I mentioned, it's about 1 in 100 for the first year. And then after year 3, it's essentially none. So it is something that I would not worry about too much. We track data very aggressively. And again, as long as everyone is in it together and, the person who's in the program is actively maintaining everything, it's just not something that should be concerned about.
Does eczema have any effect on those symptoms that you're talking about, like showing some reactions in that first year of remission?
Generally not. Assuming the eczema is present when you start the program, we're going to do everything we can to get it under control. And so as we identify eczema and try to, help with that process, generally the eczema by the time you reach remission is already under great control, or frankly in remission itself.
Okay. And then the second question was about antihistamines. Is there any data anywhere like in the world showing that can affect children developmentally as a young age? So my son's going to be 1.5 years when he starts. So that's just kind of something that I'm kind of trying to figure out if there's anything that will affect him, being so little, giving that to him every day.
For sure. So antihistamines have been around for over 100 years. It is one of the oldest medications known to mankind. So there's a lot of data and a lot of information on antihistamines. Antihistamines that are, at least the ones that we utilize in the program, are essentially ones that do not penetrate the blood-brain barrier, right? So from a neurological standpoint, they should not have any, kind of presence of that drug inside the brain. And so in that sense, antihistamines are very safe. Like they're all over the counter. They have not been proven to cause any problems. Now, long-term data, and there have been plenty of long-term studies, by the way, patients utilizing antihistamines for 20 to 30 years on a daily basis, there's been no evidence of any sort of neurological or developmental problems. Long-term use of antihistamines can cause other problems like, gut motility problems, constipation, very dry mouth, things of that nature, and dry eyes. But outside of that, again, very, very safe category of medications that we have not seen anything as far as that's concerned. And remember that we don't have the patients on antihistamines for very long. They're only on it during active treatment. Once they're done with treatment, we stop it.
Okay, so just those short years of, I don't know how long our program's going to be, but that shouldn't be considered long term to have any effect.
Yep, that's correct.
Okay, thank you.
All right, thank you. All right, next is Charlotte. Hello, Charlotte.
Hi. I had a question. My son was recently diagnosed with food allergies. And in between our initial diagnosis appointment and our follow-up to talk about OIT, we found your program. Unfortunately, he won't be able to start until he's 18 months. Clearly, he's not. So my question is, for that year that we're waiting, would you recommend that we start OIT because his immune system's more malleable right now? Or is it practice avoidance until maybe we start? What would be your guidance for that?
That's a great question. Years ago when I first started this organization, we had a lot of information or a lot of data collected on very young patients, 6 months up to 5 years of age. And we tried to be very, careful about, in fact, we did not treat patients until they were 5 years old, for a number of years. And then once we had enough data, then we had to be able to forecast, well, okay, if you're, 18 months old, what's going to happen over the next number of years? And it is still, to be very frank, it's still one of those areas where, this very young immune system it has a natural trajectory, right? So I'm not sure, what's your son allergic to?
Right now, he's just been diagnosed with peanuts and avocado.
Okay, so let's say
introducing more foods.
Fair enough. Again, one of the benefits of the program is, if you start earlier, we'll help you identify all the foods that you can't eat. So at least the dietary profile can be quite large. But let's say his peanut numbers right now are 10 or 12, something of that nature. By the time he's 5 or 6 years old, his peanut numbers will go up. There's this increased trajectory. That is something that in very young children that can sometimes have a little bit of an increase faster than we want to see or a decrease faster than we want to see. So there's a little bit of this lability that we don't, see in other age groups. So reason I mentioned that is if you started OIT, you can potentially trigger that lability. And in that sense, I'm never a fan of that. At the same time, by all means, if you want to try it and see how it works, we have a lot of our patients come back in after OIT and we will manage them after the fact and get them to remission. But ultimately it is your decision.
Okay, but sounds like maybe practice avoidance.
I just think from a safety standpoint, we've been burned a lot, by that approach. And when we're trying to undo things, it's a lot harder.
Okay.
But yeah.
Okay, thank you so much. I appreciate it.
No, you got it. Thanks. All right, next up is Sarah.
Hello. I was trying to turn my camera on. Yep. I'm Sarah. I'm actually based in Atlanta and came across this program just being involved in food allergy groups on Facebook. My daughter is 9 and is anaphylactic to eggs, peanuts, and tree nuts, except almond. So two quick questions. One being, we work hard in our home to try and focus on gut health. So we avoid a lot of ultra processed foods, food dyes, things like that, and just try to eat pretty much whole foods. So when we talk about the foods in the program, like the gummies or things like that, I'm just curious, are most of the similar proteins going to be in whole food form, or what does that look like?
Yeah, the treatment process, right? We're talking about micrograms of protein, right? So these are very, very small amounts of protein that in order to achieve those doses, you have to have pharmaceutical grade processes, right? So we have our own food laboratory. It's quite large. It produces, millions and millions of these gummies and tarts every single year. And that's important because we measure that protein going into the process. We measure the protein going out of the process, and it has to be accurate. I mean, accuracy is key to success. So in that process, we have a food scientist, full team, and so we do utilize products that we make available to you as far as what we're using and the colors and so forth. But we're not using. We try to use it as natural processes as much as possible, natural colors as much as possible. But also remember that we also are treating kids with food allergies, so we have to make sure that none of these things are going to trigger symptoms in anybody. And so in that sense, that is kind of the safety approach that we have.
Okay, perfect. And then second question is just around the overall, I would say, load on the immune system. So obviously, if the body's being constantly exposed to these tiny doses, if the immune system is in a heightened state, have you all seen where maybe there's more instances of cold or flu or things with their immune system being in that state?
Yeah, it's a great question. In fact, I would say that our job and our approach is the exact opposite of that. So remember, we are actually down regulating the immune system over time. So for example, peanut, or tree nuts, we're going to be reducing those peanut numbers before we are on those actual tree nuts. So biosimilar proteins down regulate. So if you look at our patients, remember we check annual data, roughly annual data on every single patient. And so when you start the program to the next year, we are seeing that well over 95% of our patients are seeing a downward response, or call it a down regulatory response. And that's what we want to see. And so, we have a small percentage of patients who are kind of up and down. And, again, we'll use our data science and use levers to make sure we get them back on track. But yeah, our job is to down regulate the immune system, not upregulate it.
Right. I appreciate your time. Thank you.
You got it. Thank you.
Hi, Doctor. So a couple questions. We are presently in a maintenance state with OIT for my son. He has unfortunately had some reactions at a less than the cross-contamination threshold. What kind of complications do you experience with OIT patients then coming in and attempting TIP?
That's a great question. I'm sorry to hear that. I would say, generally speaking, we are able to run our diagnostic platform pretty effectively on OIT patients. We have a pretty good idea of what amount of protein their immune system can handle based on the algorithm or based on the AI machine learning diagnostics. We will often lower the patients below that threshold. So some parents don't like that. Let's say you're already maintaining whatever, certain milligrams of peanut, we'll ask them to lower that amount, not necessarily stop it. Some cases we have to stop it because it's so provocative, it's provoking the immune system in a bad way. But most of the time we just lower it. And then we try to identify every biosimilar protein that still has the ability to have an effect, and we load that up. So we've had very good success in getting OIT patients to remission. But the front end of it does require some changes. Sorry, I think you have to, sorry, what's that? Let me unmute you again. Go ahead.
Okay, I got you. Thank you for that. And then in terms of the actual maintenance dosage, is the requirement that they would continue to ingest the gummies? Or I think you mentioned at one point they ended up actually eating the allergens themselves. Is that the intent? And then how long is that lifetime then? I would assume that they need to maintain that.
Yeah. So, the goal is the patients are, remember, they're challenging, 60 to 75 peanuts in one sitting, right? So they're consuming whole nuts at that stage. When they're in remission, they're only on treatment every, again, week, 2 weeks, 3 weeks, 4 weeks, over a number of years, it drops down. Consuming a food every 3 to 4 weeks is generally not an issue. People can do that. They just need the reminder. We have a patient app that's coming out here shortly that will help patients get to that reminder state even more efficiently. So overall, it becomes a lifestyle more than anything else. And really, our job and our goal is that once they finish the program, they do truly consume like a non-allergic person. I know it's not easy to imagine that, or it's not easy to even get to that stage, but all of our patients do. They just get to that nice stage of this being much more of a lifestyle than a treatment program.
Great. Thank you, Doctor.
Thank you. All right, next up is Sura. Good morning.
Hi, I have a 9-year-old son who has an allergy, who is allergic to cashew, pistachio, pecan, walnut, and coconut. And unfortunately, last year he had an anaphylactic incident, and then since then he developed a lot of fear of eating, going outside. So we had to go through intensive therapy, and he nicely recovered now. But I cannot get rid of the effect now that, okay, this is not just being care about food, this is about his mental health as well. So my biggest worry once we start the process at home, what are the chances that he can have any reaction? And if did you guys have any patient who developed that, who needed the support, emotional support in the office? How does it work? How can we help him to give him a confidence that we can do this? We're going to help you. It will be fine. You will be fine.
Yeah, that's a great question. And again, I'm sorry to hear that he, went through that. We've had, over the last 10 years, probably 2 or 3 cases of kids came in who are so afraid of eating that they actually stop eating. That's a difficult situation. We have a number of different support mechanisms. We have a number of different support mechanisms to help those children out. And then they were able to proceed with the program and have done well. They're in remission. I would say that we take a lot of care for cases like this because essentially the threshold of symptoms in a case like yours or your son's has to be very high, meaning like we can't get anywhere near even like an oral itch, right? Like, again, the majority of our patients, if you look at our data, just over 80% of our patients will go start to finish and never have a single symptom. So that's a very good number. It's 82%. The remainder will often have just one symptom once in the entire time they're in the program. It's often itchy mouth or hives. It's a minimum symptom. So in that sense, in your son's case, he can't even have that. Right? He can't even have the itchy throat or the hives, right? So in that case, when you come in, just let our team know and they will modify his dosing parameters. The system can be modified with all kinds of changes to, make sure that he stays below that kind of threshold. It's something that we can target as a goal. I'd also say one other thing briefly is that our gummies are really, really good for kids like yours, right? Because when they eat this stuff, they don't see it as a nut. They see it as candy, for lack of a better term, and they really enjoy it. It's like, okay, this is easy. I just eat these things. In fact, one of the things that we're looking towards building next is, all of our maintenance program, because when you're done with the program, we do ask people to eat the whole nuts. Some of the kids don't like it. They think, oh, this is, their whole life, they never eaten nuts. They don't like them that much. So we're even building out that model into a gummy or a separate type of product. So, I've been doing this long enough to know that, I'd say only about 30 to 40% of the patients with food allergies in our program will finish the program and actually say, I enjoy eating these foods, right? 60% will say, I will do it to stay healthy and to be free of allergies, but they don't necessarily love it. If you give them a different type of product, then all of a sudden they love it, right? So we have to adapt with what we're dealing with.
Okay. Oh, that's good to know that we can do conservative approach along the program. That's great. Good to know. Thank you.
Thank you very much. Great question. Next up is Carla. We'll try and get to a few more. Again, you can feel free to email your questions into our team as well. But go ahead, Carla. We'll take a couple more questions here.
Hello, doctor. Our son has EOE. He was diagnosed a few years ago, calprotectin level over 1,000. Well, we were raising him, we went through tons of different formula and so forth like that. But the actual diagnosis, he's now just about 9. My question is, even though he hasn't had actual anaphylactic reactions, it's mostly just stomach aches, some hives. We're just doing that targeted, reduction, and we're not, we just get rid of food allergens in general. And that's what we've been doing for years. And we're down to the point where, okay, the calprotectin level every once in a while we check it is normal, but, no change in lifestyle or no real recovery, just kind of we're there. And he's still, he's starting to suffer the the effects of not being able to eat what everyone else is eating. And so we're also interested in support groups because, yeah. And so my question is about support groups, and is also, would he qualify for your assistance? That's all.
Yeah,
Thank you.
no, great question. Yeah, the short answer is yes. I mean, we deal with, again, all levels of complexity, and the life of avoidance and continuous elimination of food, it does catch up to you. Hopefully, whatever GI inflammation he was having back then is going away. That's a common story. A lot of kids who have GI inflammation at a young age often do not have it later on in life. Not to say that's always the case, but that's something to think about. We do have a handful of different support groups. We have an entire nonprofit arm to our organization. I started this thing as a nonprofit initially, and that continues to support us. And the volunteer groups that we have actually do have several community efforts towards your particular kind of concerns. And it is something we're looking to even grow, especially from a mental health standpoint. So yeah, I mean, if you start the enrollment process, they can certainly give you more information.
Okay. Thank you very much, Doctor.
You're welcome. Okay, next is Min Trang. Oh, you go and unmute yourself. Thanks.
Oh, yes. Hi. Okay, so I have a couple questions. So my son is 3.5. He has a gluten, egg, and peanuts and all tree nuts allergy. We've just been avoiding everything, hoping maybe he grows out of egg and gluten since they have high instances of like children growing out of it. He has not. It has been brought up to us to start Xolair when he starts school, just to, diminish like any reactions in the case he does, get exposed to it before we start like OIT, because he's not valid for it yet. I know there's studies out there going on right now with Xolair in addition to OIT. Is there anything you guys are considering with Xolair in addition to TIP, just to like, kind of calm down if they do react during the program?
That's a great question. Xolair has been around for 25 years. I've worked with that drug for a long time. I published a lot of initial work on Xolair. Again, it's a very good drug for asthma. It has some use for sinus disease. And in the food allergy space, it allows some level of protection, but unfortunately, it's not a consistent level of protection, and it does not allow protection for all proteins or all food types. There was also quite a bit of research done on Xolair from 2010 to about 2014, where it was used as part of OIT, and the OIT combination with Xolair was not found to be any more useful or successful than kind of OIT alone. And I'll tell you, here in our organization, we don't use it much at all. We have a very small number of patients who are on it, and they're often on it for asthma or something else that they have. TIP is an actual mechanism of action, right? It's a mechanism, it's a process. That biosimilar model is what allows us to achieve this level of remission and success. And if that was not the case, then OIT would look exactly like us, but it doesn't, right? And OIT has been now around for 30 years, and it is kind of stuck in the same spot it's been. So yeah, we've not found it to be terribly useful for what we do. But again, if it's something that people are on, we have every way to manage and work with it. The patients who we have on Xolair, they're only on it for about a year and a half. And then once, TIP is kind of fully built into their program, then we do wean them off of Xolair.
Okay. All right. Thank you. I didn't know that that's an option, just, in the back in case he's not progressing as fast as, we just can. Thank
Perfect.
you.
All right, you got it. All right, we'll do 3 last ones here, guys. Next is Sharon. Hello.
Hi, thank you. Sorry, my wife just stepped away. My name's Abraham. Just a quick question, and I apologize if it's already been asked and answered. So we have a son who's 13 years old. He developed a peanut allergy late in life, maybe a year or so. So curious how this treatment, if he was to go in it and etc., what are the chances of it, let's say he gets past his peanut allergy, if it reoccurring or something new to reoccur, what can I expect? What should we be thinking about?
Yeah, it's a fair question. So we run 400 analytes on every single patient who comes to this program. And that seems like a large number, but it's important. When we run those 400 analytes, it covers every single food allergen known to modern society. So there's no way you finish the program and then have some new allergen pop up. Now, maybe a disclaimer, I don't know if there's going to be some new food that pops up in the next 50 years that's grown in some place that we've never heard of, but hopefully we'll be around by then and we'll figure that out as well. So yeah, we will always address all total allergens. And I'd say our diagnostics are so good that every once in a while we will be picking up 1 or 2 allergens that many people didn't know about because they just have avoided a bunch of foods. And picking up those things is hugely helpful.
All right, so that kind of answers my second question, that so he wouldn't be allergic to new food. But just out of curiosity, and I know there's other people waiting, why would he have developed, so late in life, a peanut allergy? We gave him peanuts when he was younger and exposed him to everything, but now 13 years old out of the blue. I'm just curious what your take on that would be.
Sure. It goes back to kind of what I was mentioning earlier, right? I mean, the immune system has these different phases of development all throughout life. Mm-hmm. Your memory towards things can change in those processes. If you do not consume large, regular, infrequent amounts of allergen throughout your life, you will always be at risk of developing food allergies. Large, irregular, infrequent amounts. I mean, Jeff Ross, who's a comedian, he just had this post. He had his first anaphylactic reaction at 60 years of age. And so two-thirds of individuals develop food anaphylaxis after age 18. And it's often to foods that they've eaten previously.
All right, great. Okay, well, thank you very much. Thank you for your time.
You got it. Thank you. Jake. Go ahead and unmute, please. Thanks.
Hi there. Can you hear me?
Yes.
Yep. Thanks for taking my questions. I've got a son who's coming up to 16 years old. He's got sesame allergy. He's had it since about age 4. In fact, we had two children. One's 2 years younger. He had a sesame allergy, but somehow he grew out of it, luckily. But yeah, my older child has got quite a severe allergy to sesame. He recently had his last skin prick test, and it came up about 150 by 120 centimeters, millimeters on his arm. My question is, if we was to start your program, what's the length of time that the program takes, and does it take longer if you have a very severe allergy as opposed to a mild allergy? I mean, he carries an EpiPen, so it's anaphylaxis.
Yeah, no, that sounds very severe. It's hard for me to give you an exact time frame without looking at data, right? But if you're only anaphylactic to one food, right, just one protein, and you eat everything else, then theoretically you don't need a lot of time, right? You just need time to introduce certain biosimilars and then start to downregulate the immune system, and then go on, something like a single dose of sesame. Single foods like that are generally about a year or even sometimes less. It just depends on their technical numbers that are present, and again, hopefully. It's accurate, right? Like in the sense that, when I see, older patients with only one food allergen, much of what is driving that food allergen are other things that they're eating. So again, remember, biosimilars can take down an immune response, or they can actually increase it. So it might be something that requires some other adjustments.
Yeah. I mean, he has other sort of food allergies as well, but they're not sort of anaphylaxis. He's got sensitivity to sunflower, poppy, chia, mustard, pine nuts, cat, dog, grass, mold, plasters. But I guess you can only really treat something that's anaphylactic, like the sesame allergy.
Yeah, we'll manage everything. We'll manage everything in the process. But yeah, absolutely. Yeah, that sounds like a very typical case that we see.
And just quickly, last question, being that I'm from the UK, if we was to come, say, and enroll in the program, how would that work? Because obviously flying over is, it's quite a big deal. Would we, because we're so far away, is there a way we can manage it more from home, less visits to you, or?
Yeah, absolutely. Most of our patients who fly from the UK, in a case like yours, you're probably only looking at, potentially 4 visits, maybe 5. But we keep it as short as possible. We use a lot of long treatment vectors, so it's just kind of long cycles. We treat patients from all around the world, so we definitely try to accommodate the total number of flights and keep it to a minimum.
Yeah, brilliant. Okay, thanks. Yeah, thanks for your answers.
All right, you're welcome. All right, and last question, Jeff, go ahead and unmute. And while you unmute, I would just say, look, we have one of these webinars every month. And again, you can always email your questions in as well. So go ahead, Jeff.
Awesome. Thank you very much for your time. was our second webinar my wife and I have joined, really considering joining your program here. So I guess two questions that I have. So a couple of our kids may be in the program. We have a 9-year-old who has quite a few allergies. One thing that we've noticed is that his IgE numbers have decreased pretty significantly over time, with the exception of wheat that's still over 100. So that's kind of the killer right there for him. Do you see when you have patients who reach recovery or remission rather, do their IgE numbers essentially no longer exist, or they still like register as allergic, but they don't have reactions to them?
That's a great question. We have to see molecular change, right? So yeah, the answer is those numbers must go down. In fact, we know what target we're going for. So we know exactly how much total biosimilar consumption is occurring and what number we're targeting. After a couple of years of remission, those numbers are generally at or near zero. So our goal is to actually get these B cells to stop triggering the production of these allergic antibodies. And in deep remission, those numbers are certainly at or near zero. In fact, many of them are flat zero.
Great, that's good to know. So if a patient is showing a history, and we have all that data over the last 9 years of his life of that decreasing, does that tend towards being like I guess an easier treatment program or something that could be, does that correlate with time?
Yeah, it's generally a favorable factor. Let's put it that way. It's something that we like to see. So an immune system that likes to downregulate itself, kind of natively, that means we can use native proteins and get that done as well.
Right. My other question is that our child is also kind of a candidate right now for a tonsillectomy for an unrelated issue. I've read conflicting studies that it can and harm and can help long-term, I guess, immunoresponses. Do you have, I guess, an opinion whether or not a tonsillectomy does affect the long-term treatment outcome for patients?
I'd say generally we don't advocate tonsillectomies. That's not necessary. But if someone has recurrent infections or very large tonsils that are causing snoring or real impact with sleep, those tonsils are so large that they're inflammatory, right? And so high inflammatory tissue states are generally not good for our program. And I'd say if that's the case, then, probably something to consider.
Get them out. All right. Well, I appreciate that. That's very helpful.
Awesome. All right.
Thank you very much.
You're welcome. Again, want to thank everybody for taking the time and join us today. Again, we'll do this again in sometime next month. Feel free to email, talk to our enrollment team. We also have physician-based consultations that are available through our enrollment team. I encourage you to take a note of that, especially for the more complicated cases. We're here to help. We're all in this together. Really appreciate everyone taking the time, and again, look forward to seeing you soon. Take care.